Good morning, all of you. Well, this is to introduce myself first. I am Brigadier Dr. Chatterjee, Professor at the Department of Anaesthesiology. Today we'll be discussing a very important topic in our medical jargon. As medical students, as doctors, as any healthcare professional, this is one of the things which all of us should know and practice, because this is a basic life-saving measure to the mankind. Now, before I start going the topic myself and for all of you, let me ask you one pertinent question. How many of you knew about this topic to be discussed today in advance? And if you knew that, how many of you have gone through this topic before you are attending this particular class? Now, a little bit of suggestion from my side. As we are all in the same faculty, we are all medical students at some time or the other, and we are brother in arms. We should remember one thing for our future avenue of life, that before you attend any class, it is always better that you read the topic in advance before you attend the class. Now, to start with, this cardiopulmonary resuscitation, the primitive form of it started, say, between 5,000 to 3,000 before Christ. The first attempt to resuscitate a newborn by blowing air into the mouth was done in the year 1780. In this context, I must tell you a few things. In the year 1757, at Amsterdam, Holland, a society for resuscitating the drowning was established, and they developed certain protocols by which they used to resuscitate those people who were taken from the sea or from drowning. In 1874, the first experimental direct cardiac massage was instituted. In 1901, first successful direct cardiac massage in man was done. In 1946, first experimental indirect cardiac massage and defibrillation technique was started. In 1960, indirect cardiac massage came in vogue, and in the year 1980, development of cardiopulmonary resuscitation established due to the works of Peter Schaeffer. Now, let us be very clear, Dr. Peter Schaeffer was not alone. Along with him, it was Dr. James Elam and Dr. Archer Gordon, who were also with him. Over a span of time, from 1959, they started developing the idea, the techniques, and ultimately in the year 1980, it got established as a definitive method of cardiopulmonary resuscitation. To remember the ironies of life and also to remember the destiny, Dr. Peter Schaeffer was nominated and projected for Nobel Prize thrice, but he never got it. Now, coming down to the causes of cardiac arrest. They can be cardiac, they can be extracardiac. Now, primary lesion of cardiac muscle leading to progressive decline of contractility, conductivity, disorders, and mechanical factors, they all accumulate to the cardiac cause of cardiac arrest. The extracardiac cause of cardiac arrest are all cases which are accompanied with hypoxic episode in the body. Now the causes of circulation arrest. Cardiac causes are ischemic heart disease, arrhythmias of different origin and character, electrolyte disorders, valvular disease of the heart, cardiac tamponade, pulmonary artery thromboembolism, and ruptured aneurysm of aorta. Extracardiac causes comes to airway obstruction, acute respiratory failure, shock due to any reason, reflector cardiac arrest, embolisms of different origin, drug overdose, electrocution, and poisoning. Now comes down to diagnosis of cardiac arrest. We should not lose time to diagnose it. Now first we should measure the blood pressure, take the peripheral pulse, and auscultate the cardiac tones. Symptoms of cardiac arrest comes at absence of pulse of great arteries, that is carotid artery. Respiratory arrest may be in 30 seconds after cardiac arrest. Enlargement of the pupils or the dilatation of the pupils may be in 90 seconds after cardiac arrest. Sequence of operations which you should go for. Check responsiveness, call for help, correctly place the victim and ensure open airway, check the presence of spontaneous respiration, check pulse, start external cardiac massage and artificial ventilation. In case of unconsciousness, it is necessary and is mandatory to estimate those things which we have discussed earlier as quickly as possible. So what we have to do? First, open the airway. Next, initiate respiration. Next, maintain hemodynamics. Main stages of resuscitation are A. Airway. Ensure open airway by preventing falling back of tongue, tracheal intubation if necessary and if possible. B. Breathing. Start artificial ventilation of the lungs. C. Circulation. Restore the circulation by external cardiac massage. D. Differentiation of the causes, drugs if required, defibrillation if necessary. Quickly perform differential diagnosis of cardiac arrest. Use different medication and electric defibrillation in case of ventricular fibrillation. Now, these are the ways you can see how you can open the airway. If the patient is supine, head tilt, neck flex. If the patient on the side, open the airway by this technique. Ensure open airway, there's a first basic thing to do. This is the next. As the picture depicts, you can see how you have to open the airway. Head tilt, neck flex. Open the airway using a head tilt, lifting of chin. Do not lift the head, tilt the head too far back because it may cause injury to the cervical spine. When you are tilting the head, please put your two fingers on the other side of the carotid to check the carotid pulse. These two things are extremely important during your maneuver. Now, this is the next thing, initiation of breathing. Either you do it by mouth-to-mouth ventilation, or if it is possible, you can use an endotracheal tube and intubate the patient to ensure patency of the airway as well as to ensure starting of ventilatory process. Tilt the head back and listen for it. If no breathing is there, pinch the nose, cover the mouth with yours and blow until you see the chest is lifting. The same thing you have to see and observe when you are intubating the patient and ventilating, whether the chest is lifting or not. So this is the algorithm. Mouth to mouth or mouth to nose respiration, ventilation by a face mask and self-inflating bag with oxygen, 2 initial subsequent breaths, wet for the end of expiration, 10 to 12 breaths per minute with a volume of approximately 800 ml. Each breath should take 1.5 to 2 seconds. Control over the ventilation, check chest movements during ventilation and check air return. Of these maneuvers, this check chest movements during ventilation is of utter importance. If the chest is not moving, then your ventilation process is not adequate, not proper. So what will ultimately come? Most important thing, algorithm for artificial ventilation. Now this is the started of C. First we had gone for A, airway. Next we have gone for B, there is a breathing. The last we are now coming to C, there is a circulation. Circulation, restore the circulation, that is the start of external cardiac massage. 2 mechanisms explaining the restoration of circulation by external cardiac massage. One is cardiac pump and another is thoracic pump. So remember, the 2 mechanisms are explaining the restoration of circulation by external cardiac massage. One is the cardiac pump and one is the thoracic pump. Now this is what happens during systole and diastole. Now when the compression is there, the blood goes towards the aorta and the heart is compressed. And when there is a relaxation of the heart is dilated and the blood from IVC, that is the inferior vena cava and superior vena cava, returns to our heart. This is what happens during the cardiac massage, the cardiac pump mechanism which happens during the cardiac massage. This blood pumping is assured by the compression of heart between the sternum and the spine. The heart is compressed between the sternum and the spine. When you are pressing, it is synonymous to systole, and when you are relaxing, it is synonymous to your diastole. Between the compressions, what happens? The thoracic cage is expanding, and as a result of which it is like diastole and the heart is filled with blood. Now this is what happens. When a person is compressing, that is systole, the blood goes to the aorta. When it is diastole, the blood comes back to the heart. Thoracic pump at the cardiac massage works like this. Blood circulation is restored. The change in the interthoracic pressure and jugular and subclavian vein valves. During the chest compression, blood is directed from the pulmonary circulation to the systemic circulation. Cardiac valves function as a normal cardiac cycle. So, what's the algorithm which is coming? Ultimately, of A, B, C, that is the cardiopulmonary resuscitation, 2 breaths, that is airway A, duration 1 to 1.5 seconds, palpation of the pulse on carotid arteries, take 5 to 10 seconds. In case of absence of pulse, initiate cardiac massage. Now, this can be done by one person and this can be done by 2 persons. Now, if it is done by one person, that compression rate 80 to 100 per minute, compression to the breath is 15 to 2. Like per minute, it should have 15 compressions and 2 ventilations. 2 breaths in 4 to 7 seconds, 4 cycles, 15 compressions and 2 breaths. That is, in total, we have to give 8 breaths and 60 compressions to have a successful cardiac resuscitation. Similarly, if 2 persons are doing it, for every 5 compressions, we have to give 1 breath. Breath during 1 to 5 seconds with each 5 compressions. 10 cycles, that means we are giving about 50 compressions and 10 breaths. This is a successful cardiac resuscitation with 2 individuals. Check the pulse on carotid arteries. In case of absence of pulse, continue resuscitation. Now, this is one of the causes of cardiac arrest, ventricular fibrillation or pulseless tachycardia. Witnessed, unwitnessed. Precordial thumb, check pulse if none. Begins CPR, defibrillate with 200 joules. If not, response is coming. Defibrillate with 200 to 300 joules. If not, again, the pulse is coming. Established IV access, intubate the patient. Adrenaline, give 1 milligram IV. Defibrillate again with 360 joules. If you see the pulse is coming, no pulse, then give lidocaine or lignocaine, 1 milligram per kg IV, and defibrillate again with 360 joules. This is the protocol and algorithm. Once you have diagnosed, you are doing a CPR, along with that, you have got a defibrillator, you have got access to medicines, and you can treat the patient in this way. Now, possible arrhythmias which can occur after cardiac defibrillation. One is ventricular fibrillation or asystole may be converted into ventricular tachycardia, bradycardia, including electromechanical dissociation, supraventricular arrhythmia accompanied with tachycardia, supraventricular arrhythmia with normal blood pressure and pulse rate. Now, if it is asystole, what to do? Start CPR as we have discussed. Ensure IV line. Give adrenaline 1 milligram in each 3 to 5 minutes or intertracheal 2 to 2.5 milligram. In the absence of effect, increase the dose. Give injection atropine 1 milligram. Again repeat within 5 minutes. Sodium bicarbonate 1 millimole or 1 milliequivalent per kg IV, and if nothing is coming back, consider electrical pacing. Now, these are the few drugs which you have to remember, which you can be used during CPR. One is atropine, one is adrenaline, one is vasopressin, one is amiodarone, and the other is lidocaine. Each has got its specific use. Like, we cannot use lidocaine in asystole, but we can use other drugs. So one has to go through the pharmacology clearly, which drug can be used for which type of cardiac arrest and can be used judiciously. With this, we have come to an end of the session today. I thank you all for attending the class. At the same time, I would request all of you that when you go back, please go through this chapter once more in your book, make your own notes, make your own valuable points, make your own vital, essential and desirable analysis of this particular topic. I wish you all the best. Thank you.